All right, Kelly and I are here today to talk about just okay is not okay when the safety and quality of oral feeding is compromised. I wanted to mention our disclosures real quickly. I am a salaried employee with Dr. Brown's Medical as the Director of Education. I have no non-financial disclosures. And Kelly receives a stipend for Dr. Brown's Medical for this presentation, and she also has no non-financial disclosures. Here are our formal objectives for today. But today, we are really going to talk about the safety and quality of oral feedings in the NICU. We want to discuss where we are with these, what are challenges to safety and quality, why it is so important, and how we can improve. And my goal is today that by the end, you will walk away with at least one important concept to take to your team or to your management to improve on your unit. So before we get started with talking about some more details, we're going to watch a few videos of some feedings in the NICU. Now, while we're watching this video, I want you to think about a few things. I want you to ask yourselves, first and foremost, does it look safe? And if we could do some of those rankings on safety from 1 to 5, with 1 being the worst, but 5 being the best and absolutely very, very, very safe, how would you think about these babies? How would they do on safety and quality? And also think about if the baby could talk, and we know they do through their cues, and that's how they communicate to us, what would the baby say? So let's look at this video and think about safety and quality.
Ruby.
Ruby. I was just say, do you need me to help you?
I think I can do it. Sit her up. So you want to sit her up so you can control the flow into the nipple, because you don't want to just flood her with milk. So just a little bit. 3 to 4 sucks.
3 to 4.
She's not really taking a breath, so I'm going to make her take a breath.
Okay.
He's like, whoa, I've never had that before.
Right? Oh.
Yeah.
Make sure you breathe, Ruby. She's going to teach you how to breathe.
Did you hear that gulping?
Uh-huh.
Part of it is she's taking such big sucks, and she's not taking breaths in between. That's that in coordination of that suck, swallow, breathe, because it's her first feeding. She just doesn't know what she's doing
Right,
yet.
she doesn't know what she's doing
so
yet.
she just needs to learn.
Okay. Well, we can teach her, right?
Uh-huh.
Okay.
So right now I'm seeing good stuff.
Oh, good. Isn't that the cutest noise ever?
Mm-hmm.
I think we get the picture, and then later on, this video can go on for a long time, but then the monitors do start. Not surprisingly, the monitors do start to alarm. So again, I ask you, does this look safe? I think probably most of you would say no, or of good quality. Does this look like a good quality feeding experience for this infant? And in fact, again, go back to that question, if the baby could talk, what would they say? Would they say, wow, this is so great, I can't wait to do this again in 3 hours? Or do you think the baby would say, oh my gosh, please stop, listen to me, why aren't you stopping? I think we need to think about that from the infant's perspective. So this baby obviously is not ready to eat, and this baby is not positioned to eat. So let's think about safety and quality. We're going to watch another video. Think about how many stress cues we're seeing. And if a baby is having multiple stress cues, what does it say about safety and quality?
Oh. You okay? So can't you see I'm turning white here?
All right. I know for some of you that's hard to watch. So definitely we would say that this baby is not exhibiting good safety and good quality, multiple stress cues, and in fact, definitely not safe at the end of that feeding. So some of you may say, well, those are pretty extreme, or maybe in your NICU that doesn't happen anymore, but even our nursing colleagues agree that safety and quality are still issues. In fact, at a national neonatal nursing conference this year, we actually did a survey and a discussion. We were discussing safety and quality with these nurses and asked them to rank safety and quality in their units from 1 to 5, and their most, with 1 again being poor and 5 being great, but the most commonly chosen score was a 3. And 3 means what? With 1 to 5, the 3 is just average. So with safety, average means it's just okay. But with safety, is anything less than a 5 even okay? So there were even some responses of 1s. So therapists, by the way, respond similarly as well. On a recent neonatal NICU survey of therapists, neonatal therapists, over 300 responders, safety was rated as a 3.5 and quality as a 3.1. So this is concerning for all of us. And I know that's why you're here today, because you want to improve safety and quality. The other thing I think about when we're actually ourselves, when we're admitting that this is happening in our units, I think about if we went to management and told management that this is a concern and here's where we think our rankings are. And of course, you could do a formal survey on your own unit about this. But if we went to management and said, imagine how parents would feel if they knew we thought this. If we actually admitted to parents, we think our safety is just okay about oral feeding in the NICU. And I think that would encourage leadership and management to say, yes, we are committed to doing this. Let's talk. Let's sit down at the table and talk about how we can help safety and quality. So just to hit home with us a little bit, how would this feel to you? And I know we can't even imagine how these babies feel because we don't have the immature brains they do. But when looking at it from our perspective, how would you feel? Imagine if you're sound asleep or in a drowsy state or just really not awake, and someone comes in and tells you have to eat and puts something in your mouth. How would that feel? Would you feel ready for that? Would it feel good? Or if you had just run a marathon and you did your hardest work and someone had asked you, your breathing's up, your heart rate's up, and someone says, drink, 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 drink. Would that be easy to do? And do you think you'd do it well? And this one, I think we can all relate to sometimes about flow and fast flow. Imagine if you had your coffee cup that you drink from every single day, and you expect the same flow that comes every morning. And again, you get up and you just pull that coffee cup. It's very expected. It's very normal. And then one morning you wake up and you drink that same coffee cup, and all of a sudden the flow is much faster. These are lightly, obviously, things that some of our infants probably experience during feedings. And they have in the past, and some still do in some cases. So how did we get here? It is definitely not all of your intention to not provide safe feedings or not have good experiences. How has this happened? Well, first, I think it's historically, right? Initially, we did not know about infants' brains and early learning experiences and how every experience matters. We now know that early experiences shape brain behavior, shape behaviors for life. Number 2, our culture was volume driven. Everything about feeding was related to volume. The first question was always, how much did he take? How much did he take? And a good nurse could get the feeding in. A good nurse could feed a rock. The focus was on volume. And also, our products and practices have been inconsistent. We're going to look at that and dive into that and how that relates to safety and quality. So historically, our feeding practices have been inconsistent. The way we teach parents about feeding varies from caregiver to caregiver. The way caregivers practice vary amongst caregivers. The nipple flow rate recommendations vary. Some of it is from a lack of education and lack of consistency in education. Everyone's learning different things, which results to practicing in different ways. And we know that consistency matters. We know that consistency actually has an impact, and that it does exist. In fact, Jackie McGrath, who is a nurse researcher who does a lot of research in feeding, has said feeding practices likely vary from nursery to nursery and may even vary caregiver to caregiver within the same unit as a result of subjective assumptions on the part of the caregiving team. Everybody comes in with their own attitudes, their own beliefs, their own education, so practices vary. And our products vary. More specifically, bottle systems and nipple flow rates. So the tools we're using are inconsistent. Typically used disposable bottle systems are inconsistent in their flow rates. And this is being published in many research articles. And in the literature, this is talked about as coefficient of variation. So if you have some disposable nipples and the slow flow ones, and you test the same nipple, but multiples of that nipple, their flow rates are very inconsistent. Sometimes they can be a little slower, but sometimes pretty fast. And when that variability happens, that measures the coefficient of variation. So a high number for coefficient of variation means there is high variability. On the other hand, Dr. Brown's Medical Precision Manufacturing and Quality Controlled nipples have more consistent flow rates and therefore superior coefficients of variation. So they are more consistent in their flow rates. And at the bedside, think about this practically at the bedside. If you go to give a baby a disposable slow flow nipple, do you really know it's a slow flow nipple and safe for that infant? And what does that tell us when there's so much variability? What does that tell us about the quality of these products? So safety is also affected by this inconsistency. What does that mean for safety to have a nipple flow rate that's extremely inconsistent? With high-risk infants who need a slow flow, is this practice of using disposable nipples even safe? And I think about if we know for sure, maybe it's been from a swallow study, that in order for a baby to, for example, not aspirate, we're in the swallow study suite, we use a disposable slow flow, and we know they need this specific flow rate to not aspirate. But then you go up to the unit and you grab a nipple out of the bin where all the nipples are. And how do we know that's going to be that same flow rate or even, around the same flow rate? According to a lot of the research on nipple flow rates, that could be much different. Is this safe? So this lack of inconsistency, the lack of consistency contributes to a lack of feeding quality and reduced safety. And consistency does affect quality. And our organizations are recognizing this. And this is from 2013, where the National Association of Neonatal Nurses reported that there is evidence that a relationship exists between the consistency and continuity of feeding management practices and improved feeding performance. In addition, consistency is also beginning to be named in competency for feeding guidelines. This is a competency. The Institute for Family-Centered Developmental Care has created some competencies for oral feeding in the NICU. And one of theirs says the consistency of feeding practices among staff who feed an infant shall be promoted, monitored, and verified. And I think this is just really interesting, and it's a great statement because it challenges all of us. It doesn't just say we should be talking about it and doing it, not just promoted, but it's also monitored and verified. So we're supposed to be being held accountable for consistency. So this is a challenge to everyone working in our units, that we're not only doing it, but we're monitoring it. So we've talked a little bit about, do you think it's safe? But I want to touch a little bit more on how the infant feels about safety. I know when you watch some of these videos and see the data on the differences in nipple flow rates and the inconsistency, we think that's not safe. But the infant, how the infant feels, and if we relate that to Mary Coughlin's work on trauma-informed care, we know that one patient right is to feel safe. So I want you to close your eyes and imagine a time when maybe you didn't feel safe. For me, it's when I am on an airplane and there's turbulence. I hate flying, and when the turbulence gets really bad, I truly feel like I'm going to die, and I have no control. And that's one thing that actually makes me even feel worse, is a lack of control. And this just makes me think of, oh my gosh, this is how babies feel, right? If a baby is feeding and they don't feel safe because the flow rate is too fast, or they're having multiple stress cues, or they're having episodes, do they feel like, oh my gosh, I'm going to die, or I don't have control over this feeding? And in her work, Mary Coughlin also states, if you don't feel safe, nothing else matters. So that's the first and foremost. It is a baby's right to feel safe, and nothing else matters. So that means if they don't feel safe, if they're having those feelings, they can't learn. They can't learn about feeding. They can't do the things that they need to do to promote their development and have really nice, positive feedings. If you don't feel safe, nothing else matters. So we've talked a lot about safety. We're going to just touch on quality here too. What does that even mean? Like, how do you say, well, do they have good quality? How do you measure that? Dictionaries, there are a couple different definitions. One is quality is a degree of excellence. The other one is a degree to which an object or entity satisfies a specific set of attributes. So how do our feedings, like how can we, what attributes are we looking at when we're looking at feeding to determine quality? We could, for an example, look at the Ludwig and Weitzman goals of feeding: to be safe, functional, nurturing, individually and developmentally appropriate, which have also become part of, it was originally in one of their articles, but it's also become part of the infant-driven feeding program. We want all feedings to be safe, functional, nurturing, individually and developmentally appropriate. So you can look at your feedings and measure in your units, are they safe, are they functional, nurturing, and developmentally appropriate? And we're going to talk about some specific ways to measure those a little bit later. So all these inconsistencies and difficulties in safety and quality, where has this taken us? Currently, 40 to 70%, and this is a statistic from an article by Zimmerman, but also Britt Pados, I think her number is around 42%, depending on ages of where you're measuring this. But 40 to 70% roughly of premature infants have some type of feeding problem at some point in their childhood. And most NICU providers do not see what this looks like later on. We're going to watch a little video just to kind of share some parent examples about what this looks like after the NICU.
And this is a foreign concept to us, the fact of, or the concept of not liking to eat. Shannon and I like to eat. Everyone I know likes to eat. And before we had the triplets that have these feeding issues, we were never aware that this issue even existed.
We have taken the triplets to 5 different feeding programs throughout the United States, which has totaled over a year of our lives living in and out of hospitals and away from home. We made great progress at the programs, but ultimately it doesn't matter which program we go to, because once home, our children have regressed. Again, it becomes a daily battle to feed them. But as parents, we have to feed our children. We have no other choice. Watching your child suffer several times a day, every time they eat, is incredibly painful.
Sometimes food makes me sick.
Billy, why don't you like food?
Because they gag.
He was 10 weeks old when we realized he's not really thriving. He's vomiting constantly. They ran a slew of tests: MRIs, X-rays, EEGs, CAT scans, emptying studies, endoscopies. It came out normal. Everything was normal. Something was wrong. He wasn't eating.
That doesn't make sense, to see a human being not eat. people, it just doesn't make sense.
So I know that's a pretty emotional video that hits home with a lot of us. And those of you who are working in outpatient clinics or in early intervention, you experience this daily, where you see patients coming from the NICU who have later feeding problems, and the struggle is real for parents. And I think it's really important. This is a Feeding Matters video, by the way, and so the credit goes to them. And I have the reference in the reference list, which you will get all the references as a PDF later on. But I think this is an important video, for an example, to show anyone who works in the NICU, whether it be on nursing orientation or when new residents come in, to show them what we do here matters so much, because this is a struggle later on for families, and we want to help them to not have to experience some of these things, or at least to reduce these numbers. So we know that safety and quality are reduced in oral feedings in the NICU, but what can we do to improve safety and quality? So let's talk about a few things. I have 5 tips that could potentially improve these aspects that you can do something about at any time. So let's talk about number 1, choose your equipment carefully. We discussed that inconsistent flow rates and how that can be harmful to infants. In fact, the inconsistency, right? So in fact, the articles that discuss nipple flow rates state that with these disposables, hospitals need to reconsider the use of product for premature infants. So choose your equipment carefully. And it's also it's not just about the nipples. The bottle systems matter too. So a traditional bottle system has negative pressure when the baby is drinking. Negative pressure creates resistance for the baby. Resistance makes it harder. As opposed to, think about the Dr. Brown's zero resistance bottle system, eliminates all negative pressure. So there's no resistance, which can improve feeding quality. So choose your equipment carefully and make feeding safer and of better quality. And not just choose your equipment available, or not just choose your equipment carefully, but also make it available, right? I know some people, I've heard people say that on the weekends, they have a hard time getting the products because they're maybe, locked in a cabinet somewhere, or they're controlled by the rehab staff. So let's work together as a team on your units and try to find a way that when therapy isn't there, that the nurses have access to these products, so that at any time they can offer the products that they want to for highest quality and highest safety on the unit. Also, number 2 is provide consistent education. We talked a lot about all the inconsistencies in messaging, and when staff receive different messages and different education, they practice differently. And this can lead to reduced quality and potentially reduced safety. On the other hand, when units complete a program, an educational program about oral feeding, such as the infant-driven feeding program, 87% of the staff in a post-survey reported that they agreed or strongly agreed that after the education, their feeding practices were safer and more developmentally appropriate. And another thing that they felt really impacted this safety and quality was the persistence of a volume-driven culture. And that is another aspect that infant-driven feeding helps transform your feeding culture, is that it helps you move from a volume-driven culture to an infant-driven culture. Number 3, make safety and quality a priority and not a choice. Developmentally supportive feedings are a priority, not a choice. Hospitals that provide safe feeding products and practices see positive outcomes, including satisfied staff and parents. So if you think about it, if our hospitals are knowingly offering infants and families products that in the literature, experts in the field have recommended that their safety should be reconsidered, Safety is not a priority. So let's get our management teams to make this a priority. We have the evidence. We have the evidence. Number 4 is measure it. So as Brene Brown, when she quoted one of her professors once said, if you can't measure it, it doesn't exist. So we may say we have safe feedings or good quality feedings, but how do we know? Are you measuring change in feeding practice or in your feeding culture? If not, it's a great time to start and get your whole team on board. I'm going to read a statement from Advances in Neonatal Care and an editorial that they had on what's new in practice improvements in neonatal care. And it is written for nursing, but I think we can all learn from it. As nurses, we are constantly mindful of safety risks, how to minimize these risks, and prevent errors or events from occurring. Nurses are uniquely positioned to anticipate potential events. Who better to provide information to our profession than the nursing providers at the bedside? And here's a great part of this statement. We need to ask whether this is the best we can do. So have we tried this? Have you all, I'm going to pause here for a second in the statement, but you're at your developmental care meeting or just at a team meeting, a NICU meeting and around, but are we asking ourselves and taking time to reflect on the fact, is this the best we can do? Are we really doing our best? I'm going to continue with the statement. Is this practice or caregiving protocol in the context of person-centered care, and are the experiences of the neonates and their parents used to guide how practice is implemented? It is important to remember that real outcome measures in healthcare are not what immediately happens, but what the neonates and their family experience over the course of their time spent in the NICU. And then they continued to have some quality improvement initiatives that were started in the NICU, pain, the reduction of central line infection, sepsis. But if you look through this list, what is missing where we can come in and do some work here? Yes, it is feeding, oral feeding. Why? Why don't we have more of that on that list? Feeding isn't something that is temporary. It doesn't end when the baby goes home. Feeding, we like to say, feeding is for life. Every interaction you have with a baby can affect how they experience feeding for life. So these are some examples of either things that hospitals, some people have already done, or ideas for how to measure safety and quality. If we're increasing the number, if you're measuring, are your babies fed according to cues? And do you have a way of measuring that? If we feed babies by cues, they will be safer. And they most likely will be of better quality. As we saw it evidence, the feedings where infants are fed when they're not fully ready and experiencing readiness for feeding, those did not look safe and they didn't look as good in quality. If we increase first feedings of the breast, a lot of research talks about how that improves feedings for a very long time, but also improving quality scores. Do you have a way to measure quality? When a nurse or anyone is feeding a baby, the parent, the therapist, the nurse, anyone feeding a baby at the bedside, are we measuring quality? And for example, you could do a pre-study of measuring quality and then also implementing a program and seeing if those quality scores improve. Anytime you do education, you should have a pre and a post measure to see if we're doing practice change. You can also look as if you're reducing stress cues and events. So do a pre-study of measuring how many stress cues or how many events infants are having, implement the educational program. One example would be implementing infant-driven feeding, and then afterwards looking at those stress cues to see, are they safer? Are they a better quality? So there are others that maybe you have done or that you can think of, but before you leave here today, I challenge you all to think of what is one aspect of oral feeding on your unit that you can measure and look at. And number 5, listen to parents. Parents know, and they're very observant, and they know about safety and quality. In fact, safety and quality are definitely topics that we talk about in many other areas, right? Prior to discharge. And in a study by Langdon, parents' developmental safety concerns about feeding practice in the NICU were related to physical safety. But in interview style, and when they reported these concerns of parents, parents reported being troubled by inconsistencies in feeding practices. And one mother said, "You know, he's a baby. He needs to learn to suck, swallow, and breathe all at the same time. So if everyone is doing it differently, how is he supposed to learn to do that?" So we definitely don't want parents feeling this way. We want them to feel that we are all doing it the same and that the baby can learn because of consistency. So let us at Dr. Brown's help you with these steps to achieve quality and safety in your units. Each of these parts of our Feeding Together system contribute to safety and quality by providing a culture that improves feeding experiences, improves parent and staff satisfaction, and reduces inconsistencies. And we do that by providing evidence-based products and practices in education and support. Our products are very consistent precision manufacturing nipple flow rates with our zero resistance bottle system and the infant-driven feeding program, so that you can provide and you can improve feeding outcomes that improve safety and quality of feedings for outcomes in the long run. So before we go, I want to look at another infant feeding and see what we think about safety and quality and what we would think about compared to those first feedings. We're going to look at this video for a moment. And you might see, those of you who are very, very observant, maybe a little rescue in the beginning, but let's compare this to the beginning feedings that we looked at. This baby looks much safer, and I think we would agree that the quality is much better. And in fact, this infant is thinking better things and could be communicating, if we could talk, better things about feeding. That it's enjoyable, that it's safe, that it's nurturing. So with all of us working together, we can improve safety and quality of oral feedings in our units. And more importantly, bring this number down. Bring the number down. Wouldn't it be great if in 1 year, 2 years, 3 years, we could all get together and say, yes, we got the number down. So I challenge all of us to leave here today with this goal in mind, to improve ratings of safety and quality in your unit with a goal of decreasing this number in the long run. And here are my references. And you can get a copy of these. And now I'd like to welcome Kelly Gardner to talk about her hospital's experience on improving safety and quality of oral feedings in her unit. Here's Kelly.
Thank you, Lisa. So as Lisa said, I'm Kelly Gardner, and I am a NICU manager in Louisville, Kentucky. And we implemented infant-driven feeding into our unit about 1.5 years ago. And some of the reasons why we decided to go with infant-driven feeding is based off of a lot of that information that Lisa has already talked about, is we knew that we needed to provide better developmental care and better safety when in regards to feeding for our premature infants. And as research has shown us, stress for a premature infant when feeding can cause a lot of other negative impacts to their brain development, impacting their long-term outcomes as they develop into little children and grow into adults. So the reason why we chose infant-driven feeding over some other methods was it gave that ability to recognize and consistency amongst providers. So recognizing that communication from the infant and reacting appropriately is key to enhancing that development of the premature infant's oral skills. And infant-driven feeding gave us a readiness score and a quality score as components of their program. And this encourages consistency between those providers, any caregiver that is feeding, not only nursing, speech, but also the parents, and autonomy of the bedside caregiver as well to say, this baby is not ready to eat at this point. So the use of the readiness skills allows us to examine their alertness, their hunger skills, and provide a guide on whether to oral feed or gavage feed. And if that oral feed is provided, it allows us to quality score the feeding based on stress signals and how progression happened during that oral feeding. It also gives us a tool to educate the families on, so what the nurse is looking at, what the family should be looking for in regards to, is their baby ready to feed? So increasing that communication and care by parent as we involve them in the care of their premature infant. So in our unit, we are a magnet facility in a large metro hospital in Kentucky. We have, at the time when we implemented, we were a level 2 NICU, 12 beds with the average daily census of 10 patients, so a smaller unit. And our population at the time was that we examined was 28 weeks to 36 and 6, looking specifically at preterm infants. Prior to implementing, we did a knowledge examination because knowledge is important when it comes to feeding a preterm infant. Not everybody knows how to do that, what skills they are, what things, stress signals to look at. And so we tested our nurses' knowledge on premature infant feeding, and our initial mean score was 66, and then they tested immediately after the infant-driven feeding program education. And those scores drastically increased as there is a ton of information in that education program. And then I did an exam again 4 months after implementation to see if they retained that knowledge, and our mean score was 86. We also looked at compliance because we all know that if you start something new, if your nurses and staff are not compliant with it, you're not going to see the results that you are intending to see. And that can skew the safety and quality of what you're doing and what you are implementing as an evidence-based practice. So we looked at, did they start the readiness scoring when they should have? And did they score quality when they provided an oral feeding? So it took us a little bit of time, but once we hit 6 months of 90% compliant, we felt that that was a steady place for us, and that we could stop auditing compliance. So initial results, I did a 4-month study. I had a very small sample size, but as far as my nursing satisfaction, one of the other things we looked at in that knowledge test prior to and after implementation was their satisfaction with the current feeding method at the time of the test. So pre-implementation, only 21.7% agreed that they were satisfied with that provider-driven method where you're focused on volume and emptying the bottle. Post-implementation, 81.8% agreed or strongly agreed that they were satisfied with the infant-driven feeding method in the practice that they were doing feeding their patients. Another question was related to feeling respected as a healthcare member of the team, and how they felt, providers valued their input. So prior to implementation, 15.2% of staff felt neutral or strongly disagreed that they were respected member of the staff. And post-implementation, all of the staff that took that final questionnaire agreed or strongly agreed that they felt respected as a member of a healthcare team. So it really brought some good insight into nursing autonomy with the infant-driven feeding program. And then we recently did another questionnaire. This is we're about 18 months post implementation, just to kind of gauge how they are feeling now with the transition to infant-driven feeding in our unit. And the question, our feeding practice are safer and more developmentally supportive now that we have launched the infant-driven feeding program. And 96% agreed or strongly agreed with that statement. And I feel less pressure now that I had to have an infant finish a bottle during a feeding. And 87% they said they agreed or strongly agreed they feel less pressure now with infant-driven feeding implementation. Our feeding practices are consistent across providers. So one of the things that infant-driven feeding encourages is that consistency with their two scoring methods. So consistency, 78% agreed or strongly agreed that they felt we were more consistent across providers now. And my input is valued regarding feeding infant cues and behaviors amongst the team. And 86% agreed or strongly agreed. So still having that good nursing satisfaction that they feel valued and respected as a member of the healthcare team. So in summary of our implementation, we increased our nurse satisfaction and feeling of respect. Our knowledge of premature infants across nurses increased from 66% to 91% at that initial post-questionnaire. And 96% of our nurses feel infant-driven feeding supports a safer feeding environment and feel less pressure to empty bottles. And infant-driven feeding is allowed for consistency amongst caregivers, improving the quality of each feeding.